Welcome to Milestones, your daily holiday snapshot of pediatric nutrition breakthroughs. Today, Professor Andrew Prentice is joined by Adeline Lescanne and Professor Mark Manary to discuss ready-to-use therapeutic food, commonly referred to as RUTF, the life-saving therapeutic food transforming the treatment of severe acute malnutrition worldwide.
Hello, my name is Andrew Prentice, and it's my great pleasure to welcome you to our podcast series, Milestones in Pediatric Nutrition. This is part of a wider series of NNI Bites Big Learnings. In this new series, I talk to some of the world's leading scientists, policy advocates, the shakers and movers of nutrition, about discoveries and interventions that have made a real impact in improving pediatric nutrition. Today, I have two guests to help us delve into the history and the current status of what we call ready-to-use therapeutic foods, often abbreviated to RUTF, an innovation that quite literally has saved the lives of millions of severely malnourished children. Professor Mark Manary is the Helene B. Robertson Professor of Pediatrics at WashU in St. Louis, Missouri. But I fancy, Mark, you spend more of your time in Africa than at home in the US. He first graduated with a degree in chemical engineering before turning to medicine, and I think that has no doubt influenced the role he's played in saving the lives of many thousands of children, as you will hear. Mark developed the first ready-to-use lipid-based therapeutic food for children and published successful trial results way back in 2001. Since then, he's worked on different formulations and published a dozen or so clinical trials. It should be said that he has also been hugely productive in other fields through leading the on-the-ground components in Malawi of some hugely innovative microbiome studies led by his colleague and friend at WashU, Jeff Gordon. But today we're going to focus just on the RUTFs. Welcome, Mark.
Thank you very much, Andrew. Delighted to be here.
And my second guest is Adeline Lescanne. She's the CEO of Nutriset, not a nutritionist first and foremost, but an industrialist. And Nutriset is the company that makes the well-known RUTF Plumpy Nut. A development engineer by training with expertise in sociology and rural development, Adeline holds degrees from Paris and Wageningen at the University of Netherlands. Her unique interdisciplinary perspective bridges across from food science, nutrition research, humanitarian action, and sustainable development policies. Now, Nutriset as a business has been the recipient of many national and international awards, including, for instance, the Patent for Humanity Award from the US Patent Office. In her own right, Adeline was Entrepreneur of the Year in 2014, made a Knight of the Order of Merit in 2016, which sounds incredibly impressive to me. And perhaps my favorite one is that she was chosen to be the Olympic torchbearer for the Normandy region in the lead up to the Paris Olympics in 2024. Welcome, Adeline.
Thank you, Andrew, for welcoming us.
It's a huge pleasure to have you. So today we're going to talk about ready-to-use therapeutic foods, RUTF, which are now accepted and promoted internationally as the standard of care for home treatment of children with severe acute malnutrition, or sometimes called SAM. I thought we might break the discussion into three sections, starting with Mark, helping us to understand what is SAM, how can it be treated, why was there a need for RUTF, and how did it all start? And then turn to Adeline and hear how Nutriset started, the challenges of manufacturing a low-cost, very high-quality product at scale. And then we can wrap up on a session maybe where we ask the question, where are we now and what would the future hold? So, Mark, tell us, somewhat briefly it'll have to be, about SAM, the challenges of treating a condition with huge mortality rates if left untreated or indeed if treated badly.
For sure. So malnutrition has been a scourge of humanity for millennia, forever. Okay. It is not primarily simply you don't have any food and then therefore you start starving, but it's certainly intertwined with immune compromise and infections. And when infection is present, even if the diet is really good, you can't very, very efficiently regain weight and regain health. So it's got these two important prongs, but once you're behind, once you've lost weight, there's no way to get it back unless you have a diet that's very rich and very much. From a personal point of view, I've been working in sub-Saharan Africa since 1985 and working very, very hard since the mid-1990s in the hospital-based care of these kids. These kids are very sick. They're brought into hospitals. The standard would be that these kids would be taken care of for some weeks, given milk-based, really fairly simple, not any kind of super ingenious sort of formulations of just vegetable oil, milk, and sugar. And in this setting, Sam was only able to be successfully treated less than half the time, successful, and went to great extents, spent lots of resources, but really kept hitting that ceiling of 45% recovery, 45% recovery, and really wanted to take it out of the hospital to the home because the hospital really wasn't working. And so RUTF fills that niche, and it fills that niche by really drawing on something that's also been used in human diets for millennia and centuries. And that's a low moisture food. So there's not very much water in it, and water is needed for bacteria to grow. And so it's a very safe, a very clean food. And that's the attraction of RUTF. And I think the breakthrough that was happening around 2000 in that area.
We'll come to that in a second. I think it's a lovely story as to how the idea started. Just before we go there, let me just say that in another Landmarks podcast, we're going to be talking to someone about the more clinical aspects of treating the severely malnourished child, whether they've got marasmus or kwashiorkor, and the very great difficulties. But the point you're making is that once you have stabilized a child, instead of keeping them in hospital for weeks, which of course has huge resource implications and means we can't treat all the children, then it's safe to get them out and treat them in the community. And this is where our UTF comes in. So you've described then how resource intensive it is. We needed to get them out. And legend has it that the idea for a lipid-based food started over a breakfast table when our mutual friend and colleague André Briend looked at the ingredient list of his children's jar of chocolate paste. And he noted that the macronutrient content was similar to WHO recommendations. He also noted that the jar could be left on the table for, if necessary, years without it going moldy. Am I on the right lines? Is that really the story, Mark?
I think that's part of the story for sure. And it just draws back on, like, in the Middle East, halva has been used there for a couple of centuries. We are actually engaged in a project right now, feeding children in Gaza with halva. And what's the difference between halva and RUTF?
Yeah.
Well, it's peanut and sesame.
And the key content, as you've already indicated, is the low water content means that bacteria don't multiply.
Exactly.
Great. So we start there. Tell us about your first RUTF, how you took the story forward from there and onto clinical trials.
Well, I mean, I didn't know André, and I got a cold call email 25 years ago or so. I'd been working in a village at the time, and André was apparently quite persistent about asking anyone who walked by on his job in Paris, would anyone be interested in such a thing? And he developed some prototypes, and certainly Michel, Adeline's father, was involved in that. And to an American, what's the low moisture food of choice? Peanut. So that was sort of how the ideas came about. I said, send me some food and I'll do a clinical trial. And I'm a doctor and had been doing trials at that point for a bit of time.
And the trials were successful, as you've already indicated. What kind of differences were you able to achieve, Mark?
Well, I mean, it was more than successful. It was just very dramatic. So on one level, with this 45% recovery ceiling was broken. We saw 90% recovery with RUTF. But interesting about that trial too is we also had a couple of other arms in home-based therapy, and one of them was just corn soy blend and vitamins. And even in that arm, the recovery rate was 75%. So that right away told me getting out of the hospital was a good move, and we have to keep that fundamental.
And was that readily accepted by the international community, by WHO and so forth?
No. I mean, the party line at the time was reckless, careless, dangerous. Why would you take children out of the hospital who are they're so sick?
So that's why I'm asking you the question. How did you get over that bit, Mark?
We just continued to do consecutive trials. I mean, the first year's trial was some Plumpy nuts sent to us. The second year we were making it in the kitchen. When I think the first time I actually saw André in person, he came down to visit me in Malawi, and we went over to the MSF kitchen and just put together something and started using it. And then we did a really big trial in an anticipated famine year where there was a lot of external support to feed kids in Malawi, and we just went head to head with home-based therapy, mothers feeding their own children peanut butter food, and the results were again striking. 48% recovery with, attending to every detail of this inpatient therapy, and mothers feeding their own children peanut butter food, 85% recovery. And that's thousands of children were involved in that trial.
And so that started to take the scales from people's eyes. They started to re-evaluate their old prejudices and I guess scratch their heads and say, yeah, this seems to be working and is safe. It's not reckless.
Yeah, I think so. I mean, I at that time, I'm a very empiric person, and try things. And if they're working, then I try more of them. And I had already worked in Malawi at that point when we first tried the RUTF for 7 years. And there was no doubt to me, you weren't going to convince me otherwise that if our hospital was better things would happen or something like that. So I would persist, and Andre's pretty persistent too. And certainly the Nutriset people, well, we were in close partnership at the time. And I think we made a pretty driven effort to get this on.
Yeah, it's a powerful combination. And one of the things I love about our landmark stories is that it's usually a combination, maybe of a clinician working in the field as you were, plus someone who's absolutely driven by the advocacy, and then people such as Nutriset who really help push it forward. So thank you, Mark, for the introduction. Adeline, let's come to you. Nutriset's website proudly tells us that your products have treated over 65 million malnourished children. That's an enormous number. How did we get here? Take the story forward from us, from your father who knew André, and how we've got to where we are today.
Yes, for the story, I think that we were working on products already to treat malnutrition, and André come to work with us. And so with Michel, they invent the RUTF concept. I'm not sure that it was during breakfast, but for sure, they invent the concept with the idea to have the good nutritional value, of course, but to have a suitable product for all the chain for children, because it was very important for them that any child eating the product has pleasure to eat the product and has pleasure to eat. But also it was product more simple for logistician, for distribution, for transport. So I think it was also a part of the solution to ease the full process to reach the child. If we are able now to reach so many children with our product, of course, it's first due to the implementers, the UN program, NGOs, health center from government. They are the one who implement and really treat the children. But since the beginning, the Nutriset group wanted to fight malnutrition, and fighting malnutrition is also, of course, there is all the things mentioned by Mark, where a child is already malnourished. But we were thinking that part of the solution should be also to develop the local economy, to use the local raw material, and to be able to bring competencies and to bring the product closer of the needs. So we develop a network called Plumpy Field, and where we start with Mark. This network is a network of independent entrepreneurs in the programmatic countries, able to produce plum peanut, so the RUTF, with the same quality as we can have in France or in US. So we are very proud of that. We really believe that the solution is not only the product, but the solution is the holistic approach of malnutrition, and being able to produce locally and to work with the government for us is really a part of the solution.
That's so important. I wonder if I might interject a couple of points. First of all, one that I just want to really underscore, which you mentioned as you were talking, Adeline, which is that palatability is really important. Listeners should remember that when a child is really sick, they just generally don't feel like food. And there are also amino acid changes in the brain which suppress appetite and things. So it is really key that they have something that they would like to eat, and you made that point very nicely. The second point is that quality control is so important. We haven't really described the composition of RUTF, and it might be useful to throw that in, but you've heard already that the base product would be, a nut, which contains oils, proteins, some carbohydrate, but not much, and a mix of multiple micronutrients and vitamins. Now, there could be many companies or little, almost shacks in Africa that would look at this and say, hey, I can make a buck from making this. This is pretty easy. In fact, we sell this already on the market, ground up peanut butter. But the point you're making is that by setting up the field control aspects, that you maintain quality. And let's not forget that one of the quality issues is that ground nuts can be contaminated with aflatoxins, so that's important too. So the bottom line is that it is really important to maintain good quality control on the product.
Yes, the quality control of the product is very important. It starts with the quality control of the raw material. Of course, the groundnut, but also any other material we will use. So we need to work closely with the producers. And after the raw material, we've got a full process on quality control inside the factory, from storage of raw material, mixing, etc., and storage of finished product. And finally, to be sure that the product is good, we do a lot of analysis during the process and to rely on the product at the end.
And how many countries are making their own RUTF?
I'm not sure. I would say 12 or 13 today, maybe. But from our network, we are based in France and US, but in Haiti, Burkina Faso, Nigeria. We were in Sudan, but due to the war, we had to stop it to go to Egypt, Ethiopia, Madagascar, and India.
Okay, great. I mean, it's not a trivial process to set this up, so that's great. But of course, there's many more countries you haven't mentioned where it would be desirable to develop the programs and the factories. Mark, I think there are some Me Too's out there, that there are some other possible, not plumpy nuts, but similar products. How are these getting on? Is there much around, or is plumpy nut dominating the field?
I would say that the basic product is very, very, very similar, no matter who's making it or what the proprietary name that it's called. So actually efforts to change that to have largely been unsuccessful. I mean, I feel many times that we were just lucky the first time to really have hit on a winner. And even though I may not be able to tell you, I mean, we know essential things like milk need to be in there, but what, there's a gap. Why peanut? To me, I didn't really choose the peanut, but I accepted it quickly because I knew of its low moisture properties. But it wasn't a process of a food development process of trying lots and lots and lots of different ingredients early on. And since now, when people have it, hasn't worked out very well.
Okay, you know, I must tell you a little anecdote, which is that back in the 1970s, I can still remember a meeting in Roger Whitehead's office with John Mason, where he was telling us about a groundnut-based product that was used for dropping into famine zones. Now, these were a more chunky biscuit type of product, which is presumably a kind of a forerunner to Plumpy Nut. And we, in fact, use those in our randomized trials of supplementing pregnant and lactating women in the Gambia right back in the 1970s. So there was a forerunner already then. And I wanted to ask the question, so to what extent, what, Adeline, is the division? You may not know this number, but or roughly, what is the division between product used in an emergency situation? Let's say we've got an earthquake or a tsunami or whatever, where I believe RUTFs are sometimes flown in, Haiti you mentioned, as opposed to sort of regular clinical use in countries.
You're true, I don't have the numbers. I think that more and more it's used in a regular place. But I don't know.
No, okay. Well, in a way, that's a good place to be, because what I think we're saying is that, thank goodness, famines in most places, apart from certain war-torn areas, and Mark, you've already mentioned Gaza, Adeline, you've already mentioned Sudan, we thankfully have fewer famines in the world than we used to even 40 or 50 years ago. Now, let me perhaps start pulling this together with the following question. Adeline, from the perspective of a manufacturer, could we or do we market Plumpy Nut as opposed to relying on UNICEF or other NGOs, World Food Programme, to supply it?
This product has to be used under medical supervision, so we will never market the product out of health system. Of course, the UN are the main purchaser today and the big NGOs, but we are very happy because we see more and more government purchasing directly the product and to put it in their nutrition center.
Okay, forgive me, but why do you say so strongly that it has to be used under medical supervision?
Because the child suffering from acute malnutrition, maybe Mark, you will tell me that it's not exactly the truth, but child suffering from acute malnutrition can have other disease, and we need to make sure that the other disease is treated also. So once we are sure it is only malnutrition, so it can be taken at home and come back to the nutrition center or other every week or 2 weeks.
I guess what I'm thinking is the following, that there are many children who are undernourished, if not severely malnourished, who their mums and dads are going into the local duka, the little bitikoto or whatever in Africa, and buying some frankly rubbish foods in little sachets hanging over a bar. And wouldn't it be great if they were buying a much better product, such as Plumpy Nut? That was what was going through my mind, rather than so much the early phases of treatment of malnutrition.
But of course, there is a range of other type of product that can prevent acute malnutrition. And this product could be on the store and could be more available for the family directly, but not RUTF.
All right, good answer. So do we see an increase in the amount you're producing? What's the market trend at the moment, Adeline? Are we stable, increasing, decreasing? How is the need going?
The needs are increasing, but the demand is decreasing drastically with of course, the Trump administration, but also the development aid policy in European country decreasing also. So today we are in 25, we are producing maybe 2 times less than the year before. So we are missing so many children due to the lack of financing of nutrition.
Wow, my goodness, as we come to the end of our talk, I'm glad I asked that question because it is a crucial one. Unfortunately, the Trump administration has created, not only within US support, but across Europe, as you just pointed out, Adeline, this pressure on global health budgets that is having a huge effect. To myself, it has a huge effect on research funding. To others like yourselves, it has a huge effect on the aid that is being given to children. So that's perhaps a pessimistic note to finish on, but we will get through this, and I'm sure there will be better times ahead. So, Adeline, Mark, I'm really most grateful to you for talking us through the history of this really life-saving innovation, RUTF, and for sharing some of the challenges, as we have just done a moment ago, that had to be overcome and still have to be overcome to bring the initial vision to a reality. As I often do in these milestone podcasts, it remains for me to thank you on behalf of the millions of desperate parents struggling to bring health back to their critically ill, malnourished child. You've done a great job, and I'm sure there'll be a special place in heaven for you. Thank you very much to both of you.
Thank you, Andrew. Bye.
Thank you, André.
So thank you, listeners, for joining us on this edition of our podcast, Milestones in Pediatric Nutrition, part of the NNI Big Bites, Big Learnings series. Please subscribe through the NNI website or the NNI 365 app to ensure that you don't miss our future offerings.
Thanks for listening to Milestones. Explore more expert insights on the Nestle Nutrition Institute website and follow us on our social channels. See you Monday for another milestone in nutrition. Wishing you a season of learning and discovery.